Hello, this is the 9th video in the Fireside Chat series on contextualizing care. Up till now, I've been describing the process of contextualizing care as a set of steps, beginning with recognizing contextual red flags, probing them, eliciting contextual factors, and so on. But I'd like to pause here and reflect on how weird it is that we have to teach this at all. My audio coding team, which listens to thousands of medical encounters, are still surprised by the questions that doctors don't ask. And I was thinking about this the other day in clinic when a resident presented a patient to me. This was an elderly man who was losing weight. He probably wasn't taking his medications. He was quite frail and overall just wasn't doing well. And I asked, does he live alone? And the resident, they didn't know. They hadn't asked the question. So I think there are a couple of things going on here. The first is what I refer to as the efficient task completer mindset. You may recall in the third video, if you saw it, a patient, this was actually an actor portraying a patient in our unannounced standardized patient study. And the actor was trained to drop a hint, a contextual red flag early in the medical encounter, indicating that maybe they couldn't afford the expensive medication they were taking. And the actor was trained to sigh and say something like, boy, doc, it's been tough since I've lost my job. And all too often, over the sound of clicking on a keyboard, we would hear a response along the lines of, sorry to hear that. It's been a tough economy. Any allergies? And then the physician would just keep on going. It was almost as if the doctor-patient relationship had been replaced by the doctor-computer relationship. So that's what I mean by the efficient task completer mindset. But I don't think that's a sufficient explanation to account for the profound level of detachment that we so often hear. And to explore that phenomenon, I'd like to tell you about Arthur. Arthur was a patient I took care of when I was a resident many years ago. And Arthur deeply affected me. And I want to share this story because I think it illustrates how we hold patients at arm's length, often out of fear and insecurity, and in some cases, prejudice. And how doing this can, in this case, profoundly affect a patient outcome. And also, I think, isn't good for us. I think it contributes to burnout. So after telling you about Arthur, I'm going to discuss the psychology of what I think is going on. What are we doing as physicians that causes this? Why are we doing it? And how can we change? So let's get started. Arthur was a 26-year-old man who had been admitted many times for sickle pain crises. He had a reputation for being demanding of certain narcotics, typically meperidine or Demerol, and then leaving against medical advice. He often required blood transfusions and developed hemochromatosis, which is iron overload, and that damaged his organs, including his liver. Arthur was advised to take defuroxamine intravenously, which is an iron chelation therapy, but he never followed through with hematology referrals. He was considered demanding, unreliable, belligerent, and manipulative. I was advised that he was drug-seeking and that I should be on my guard. So I just want to pause at this point and ask, why were the doctors so frightened of him? Why were they using this kind of language? Arthur was physically slight, and he had a profoundly disabling disease. He wasn't a physical threat, to say the least. Although he'd never finished high school, the physicians caring for him feared that he could push them around. What motivated him to behave in such a way that he elicited this kind of a response in the physicians caring for him? Looking back, I can see that he was someone who had no power and who lived with severe chronic pain. In the hospital, he had no say over what he ate or how he spent much of his day. Keeping his doctors off balance might have given him some sense of control. While they held him at arm's length, he took swings at them. He was engaging negatively, and they weren't engaging at all. Conversations between Arthur and his doctors would go something like this. Arthur would say, "Are you saying you don't believe me when I tell you Demerol is the only painkiller that works for me?" And then a doctor would reply, "Well, it's not that I don't believe you, it's just that I think we should try something else." And then Arthur would say, "Well, if you believe me, then why aren't you listening to me?" So basically, the dynamic was that they feared telling him what they really thought, and he called them out for it. I met Arthur when I was a junior resident on the inpatient service. As soon as I entered his room and started talking with him, I got the sense that he seemed relaxed, he made good eye contact, and he used language with agility. Before going in there, I'd read his records, and I wanted him to see that I had. I felt like this was essentially an audition. So I told him we should switch him from meperidine to morphine, since the former could cause seizures, is more addictive, and leads to escalating dosages. And at the time, that was the current thinking. And he predictably objected, saying, only Demerol works. I recall this was a common response in those days when caring for patients with chronic pain, particularly sickle cell patients. Somehow they always wanted Demerol, and we always felt that the reason was that it would give them some kind of high. So anyway, I responded, I am personally not comfortable keeping you on that medication, as I believe it is more likely to harm you, and I'm not prepared to take that risk. Arthur replied that he'd probably have to find another doctor. And I said I hoped that he would stick with me because I was looking forward to getting to know him and seeing if I could be helpful. And I just have to pause here to reflect back on what I was really thinking when I said that, and I'm not sure I really believed what I was saying, but somehow I said it anyway. I felt like we needed to move forward. So Arthur grudgingly agreed to come to my outpatient clinic in a week, and not surprisingly, he didn't show up. It was tempting at that point just to drop the whole thing, but I knew that that was the pattern that he was used to, and I wanted to break the cycle. So after clinic, I called him. When he answered, he said he couldn't make it because he was watching over a couple of nieces and nephews, and I could hear children playing in the background. I told him I wanted him to see a specialist to get on a medication called hydroxyurea, which could reduce the frequency of his sickle cell crises. He agreed, and I placed the consult. On the scheduled day, I logged in, and again, perhaps not surprisingly, he was a no-show. So I called him again, and he said he'd forgotten. And I replied, Arthur, you're too smart to forget something this important. What is going on? Arthur paused, and then he told me that a friend of his had gotten shot, and he was feeling awful about it. We discussed what had happened. He told me that he wasn't involved with gangs anymore, but had been, despite his sickle cell disease. I remember him then saying, I'm an old man now, and I don't get into that kind of trouble anymore. We laughed about that. Again, Arthur was 26. After that conversation, Arthur stopped missing appointments with me. He also followed up with hematology and started on the hydroxyurea. They were successful at getting him on home infusions of defuroxamine, iron chelation therapy. That's pretty involved. He had to have a nurse come to the house and administer 8-hour infusions using a pump, which he did at night. At this point, however, iron had already infiltrated his heart, causing irreversible damage as well as a cirrhotic liver. He and I continued to keep in touch, and he'd come for appointments, and although I felt like we had a good bond, there would sometimes be outbursts. He would get angry, demanding I switch him back to Demerol, saying he had no reason to see me if I wasn't going to treat him right. While these outbursts were disconcerting to me and a bit hurtful, I realized that they were an indication that he was struggling. So I'd say something like, I'm sorry, Arthur, that you're so miserable. And then I'd ask him, what's going on? I remember he started talking about dying. And when he did that, I thought to myself, this man is smart. He's figured this out. I realized I hadn't even really started to process the fact that he probably wasn't going to get better. Over time, I came to appreciate that his outbursts were now because he felt safe that I wouldn't abandon him. I also remember that whenever I had an opportunity, I would let him know that I recognized his intelligence and insight. He'd nod like he knew he was smart, but probably hadn't had it often acknowledged. One morning, the nurse who was responsible for those nightly infusions called me to say that he had died. I called his home and spoke with his mother. It was the first time I had a real conversation with her. Often she answered when I'd call and just passed the phone to Arthur. But this time, we talked briefly. I got information about his funeral and turned up one afternoon to attend in the Auburn, Gresham neighborhood of Chicago. I remember as I parked and stepped out of my car, feeling a sense of discomfort, looking around and realizing I was the only white person in sight, a reminder of what Arthur might have felt when he came to my neighborhood for care. When I got into the chapel at the funeral home, I approached Arthur's mother, and she clasped my hand. My goal was to be as invisible as possible, and I sat in a pew at the very back. But an usher came over and said Ms. Barnes, his mom, wanted me to sit next to her. I felt undeserving, but followed him up the aisle and sat next to her, looking directly at Arthur in his open casket, seeing him one last time. Over the years, reflecting back on what happened, I realized that Arthur could have lived a long life if he'd gotten chelation therapy earlier. But his chart had labeled him as, again, quote, non-compliant, unquote, and not a candidate for medication that requires nightly infusions and close monitoring. But Arthur was compliant when he was treated with caring and respect. The problem was that his doctors had been turned off by his behavior. They took it personally. And this is where I think it's useful to introduce a couple of concepts that are tightly interconnected that I'm going to talk about next. Fundamentally, Arthur's physicians lacked the qualities to engage with him because they lacked boundary clarity. These are concepts that emerged in my mind during conversations with Simon Oster, a family physician and psychiatrist who influenced me deeply and who I had many conversations with over the years. So, boundary clarity is basically knowing what's me versus what's you. And that's essential to not taking things personally. In the case of Arthur, what we saw is that his doctors seemed offended by his negative critiques of them. They seemed to experience feelings of helplessness and loss of control. At least, that's my interpretation. They didn't feel they could say what they were thinking. And because they were reacting to their own emotions, they were not able to analyze and respond appropriately to his. As a result, they were not open to engagement. So, to engage is to relate to other people without adopting a persona. To be who you are without holding the other at arm's length. When you're engaging, it feels honest, it feels genuine, and it feels nourishing. But the question is, how do you do that when the other person is trying to get under your skin, to challenge and to manipulate you? That was the dynamic. In other words, how do you engage when someone like Arthur is pushing your buttons? So, this schematic diagram illustrates what happens when physicians don't have boundary clarity, and as a result, consciously or unconsciously, they hold their patient at arm's length. If you look closely, you'll see an oval for the physician and an oval for the patient. The line between them is the physician's arm, pushing the patient away. Of course, it's a metaphorical arm. What's key here is to notice that the oval around the physician is not solid. It's permeable. And that's to show that this physician lacks boundary clarity. I also just want to observe that this interaction between patient and doctor is occurring within a larger sphere, and that sphere is the medical context. I included that because it's important to remember that the encounter between a doctor and a patient is really just an encounter between two people happening in a particular context. This diagram could also be drawn to describe any interpersonal interaction between, for instance, a romantic couple, two people at work, or the grocer and a customer in the checkout line at a supermarket. In any event, the key point is that what we are seeing here is a doctor with porous boundaries holding a patient at arm's length because they are protecting themselves from the emotions they might experience were they to engage. And because the emotions the physicians were feeling were drowning out their capacity to see what might be going on with their patient, they failed to see that he was suffering too. In fact, far more than they. He was alone and powerless. They, the physicians, were the ones with the power, but unfortunately, also deep insecurity. What the physicians were unable to appreciate, because of their lack of boundary clarity, was that Arthur's dysfunction was part of his illness, given the context in which he was getting care. It was all part of the package. So in essence, these physicians lacked the personal qualities, and therefore the professional qualities, to care for their patient effectively. They were functioning as technicians rather than as professionals, or, as I prefer to say, as healers. Now, in this diagram, I've put a solid line around the physician. This is a physician who has boundary clarity. And when that happens, the two ovals come together. The physician is no longer holding the patient at arm's length. They can engage. There's a connection between them. I want to emphasize that this is a natural state. Engaging is just what happens when two people are relating to each other as equals without fear or a desire to assert their will. It's the conditions under which people basically get to know each other and to care. Now, I realize that the story of Arthur is somewhat extreme. He was making this difficult, and one could say that it's understandable that a lot of physicians found him challenging. And while I know that's true, I don't think we can let ourselves off the hook so easily. Patients struggle with so many things that can make them behave in difficult ways, and it's up to us, as healthcare professionals, to be comfortable with that, to not be fearful or pull back. In other words, it behooves us to be clear about our boundaries so that we can react to what's in front of us rather than to just what it's eliciting in us. We know the difference. We have to. And as an aside, I also want to point out that, as I've mentioned previously, physicians are detached even when patients are not challenging. I talked earlier about the efficient task completer mindset, where there's just a failure to engage because physicians are preoccupied with their to-do list. Unfortunately, that detachment, that holding patients at arm's length, becomes a habit. But the point I want to add by telling you about Arthur is that even when you're not caring for an Arthur, it can become a way to retreat from any emotion or uncertainty that comes up during visits even when they're apparently routine. And finally, I'd like to show a third version of the diagram, this time with a physician who, rather than holding a patient at arm's length because of a lack of boundary clarity, instead intrudes on the patient's boundaries, is essentially disrespectful of who the patient is. A common example that comes to mind is when physicians badger patients to lose weight in a way that is not therapeutic, but rather reflects the physician's preoccupation with their own prejudices. This kind of behavior has come up in media reports of widespread complaints by patients reporting what is sometimes called medical gaslighting, in which physicians are dismissive or demeaning. This kind of behavior seems to happen most when patients are low power or low status, such as when they are poor, black, or female. Medical gaslighting is the worst kind of behavior, worse than holding patients at arm's length. I would say that if you lack boundary clarity, it's better not to engage than to engage negatively. As someone once said, while it's always best to be yourself, if you're a schmuck, be someone else. Now, what does boundary clarity and engagement have to do with the theme of this Fireside Chat series on contextualizing care? As you'll recall, contextualizing care is a 4-step process. First, there's a contextual red flag, which is that clue that something in a patient's life situation might be impacting their care, and clinicians are supposed to recognize it. Second, there's a contextual probe, which is any attempt to inquire about the contextual red flag to find out what is going on in that patient's life that could be impacting their care. Third is the contextual factor, which is anything the patient shares, reveals about what's going on in their life that is in fact impacting their care, and it's typically revealed in response to a contextual probe, although sometimes patients disclose it voluntarily. And finally, there's the contextualized plan of care, which is a care plan that takes contextual factors into account so the care will be effective. Now, in the case of Arthur, those frequent missed appointments were a contextual red flag. The contextual probe was a clinician repeatedly reaching out to the patient to find out why. The contextual factors that were revealed during those phone calls included the patient's child care responsibilities, the grief following the death of a friend, and a history of negative interactions with his providers. And the contextualized plan of care included persistently demonstrating an interest and a desire to engage, combined with boundary setting. Now, if you remember back to the 12 domains of context, you'll recall that the 6 on the left pertain to life circumstances, and the 6 on the right pertain to drivers of behavior. For Arthur, the contextual factors were focused in 3 domains. First, of course, there was the competing responsibilities, as in when he missed appointments because he was caring for his nieces and nephews. The drivers of behavior were his emotional state, following the death of his friend, and his troubled relationship with healthcare providers and the system in general. Note that boundary clarity and engagement were particularly important for responding to the domains on the right side of the chart, the drivers of behavior. His dysfunctional relationship with his healthcare providers, in particular, were deeply rooted in their lack of boundary clarity and therefore unwillingness to engage. I think the point that I'd like to leave you with here is that the 4-step process to contextualizing care is not like painting by numbers. In the case of Arthur, contextualizing care required the capacity to engage with him. I picked this case to share with you because it illustrates how the failure to engage, the failure to respond to the broader context in which this man was suffering, probably killed him, or, more specifically, denied him the opportunity to benefit from life-saving care. I picked the case because I wanted to illustrate how serious an issue this can be. Far more often, I realize, the failure to engage just results in what I've called the efficient task completer mindset, the focusing on our own agenda. Regardless, we're disengaged and holding the patient at arm's length. Contextualizing care requires prioritizing the well-being of the patient, often at the expense of getting through our expected checklist. It requires listening to that intuition that until I figure out why this patient isn't adhering to their treatment plan, nothing else I do is really going to make a difference. Sometimes when I talk about this, residents will say, "But what if I don't have time?" And I'll respond, "Look, if you know that they're not going to get that mammogram or that colonoscopy anyway, until you sort out why they keep missing appointments and not taking their medications, what's the point of ordering them?" When a patient's behavior seems irrational or puzzling or dysfunctional, a caring response is to ask them about it. Sometimes when I suggest this, residents will say, when I start asking questions, it's like opening a Pandora's box and the patient goes off on these tangents. I'll suggest that when that happens, they gently redirect the conversation. The physician's responsibility is to be sure that the limited time during a visit is spent in the best way possible to really help the person in front of them. I'll also suggest that they briefly document in their note why they couldn't get to the routine issues and will return to them at a later visit. I'd like to close with a deeply insightful quote by Simon Auster, who said that the best way to show you care is to ask questions. If you remember back to the second video, where we talked about Ms. Garcia, who came to the emergency room 4 times before anyone asked her why she kept missing her hemodialysis, we concluded that they'd failed to probe the contextual red flag, which was her frequent missed hemodialysis. That was true, technically. But I think what Simon would have said is that we also failed to care. If the doctors had cared, they would have asked her right away, what is going on? So that's it for now. As always, thank you for your interest.